Hello friends, today we are going to discuss here about NEET SS MCQs or MRCS MCQs for trauma surgery. A patient with penetrating injury of chest undergo thoracotomy if there is more than 500 ml of blood which drains from the chest tube when placed, or there is more than 200 ml per hour of blood for 3 hours from the chest tube, or there is a air leak that persists for more than 48 hours, or there is documented lung injury on CT scan. So which of the following is the best answer here? If you want, you can pause this video and think about the answer. So what is single best answer? Take 60 seconds. So best answer here is there is more than 200 ml per hour of blood for 3 hours from the chest tube. Why this is best answer? Let's discuss. The most common injuries from blunt and penetrating thoracic trauma are hemothorax and pneumothorax. More than 85% of patients can be definitively treated with chest tube. The indication for thoracotomy includes significant initial ongoing hemorrhage from the tube thoracostomy and specific imaging identified diagnosed. Concerns the patient who presents after a delay even when the initial chest tube output is 1.5 liter. If the output ceases and lung is re-expanded, the patient may be managed non-operatively if hemodynamically stable. Indications for operative treatment of thoracic injuries like initial tube thoracostomy, drainage more than 1 liter in penetrating injury and more than 1500 ml in blunt injury. Ongoing tube thoracostomy drainage more than 200 ml per hour for 3 consecutive hours in a non-coagulopathic patient. So this is our answer. Second option, select hemothorax despite placement of 2 chest tubes. Selected descending taunt aortas. Great vessel injury endovascular techniques may be used in selected patient. Pericardial tamponade, cardiac herniation, massive air leak from chest tube with inadequate ventilation. Tracheal or main stem bronchial injury diagnosed by endoscopy or imaging, open pneumothorax, esophageal perforation, air embolism. These all are indications for thoracostomy. Now, next question. 25-year-old man has multiple intra-abdominal injuries after a gunshot wound. Celiotomy reveals multiple injuries to small and large bowel and major bleeding from the liver. After repair of the bowel injuries, the abdomen is closed with towel clips, leaving a large pack in the injured liver. Within 12 hours, there is a massive abdominal swelling with edema, fluid and intra-abdominal pressure exceeds 35 mmHg. The immediate step in managing this problem is to. So, I'm going to question visible. The administered albumin intracavenously, give an IV diuretic, limit IV fluid administration, open the incision to decompress the abdomen. So guys, which is a single best statement here? What is the best answer? Try to think and write in a comment section. So what is the best answer here? So best answer here is open the incision to decompress the abdomen. Why so? Cardiac, pulmonary and renal problems develop when invasive ascites compresses the diaphragm and the inferior vena cava. Dialysis, diuresis and increasing serum oncotic pressure will not correct this problem rapidly enough to save the patient's life. Opening the incision relieves the intra-abdominal pressure. There are few reports of sudden hypotension after this maneuver, but volume loading has largely eliminated this problem. So that's why decompression is must. The most appropriate treatment for duodenal hematoma that occurs from blunt trauma is exploratory laparotomy and bypass of duodenum, exploratory laparotomy and evacuation of hematoma, exploratory laparotomy to rule out associated injuries, and D option is observation. So guys, if you want, you can pause this video and try to think your answer in 60 seconds and try to answer in a comment section. So the single best answer here is observation. Why observation? Let's discuss. Duodenal hematomas are caused by direct blow to the abdomen and are more often in children than adults, but blood accumulates between the seromuscular and submucosal layers, eventually causing obstruction. The diagnosis is suspected by the onset of vomiting following blunt abdominal trauma. Barium examination of the duodenum reveals either the coiled spring sign of obstruction. Most duodenal hematomas in children can be managed non-operatively with nasogastric suction and parenteral nutrition. Resolution of the obstruction occurs in the majority of patients if this therapy is continued for 7 to 14 days. If surgical intervention becomes necessary, evacuation of the hematoma is associated with equal success but fewer complications than bypass procedure. Despite a few existing data on adults, there is no reason to believe that their hematoma should be treated differently from those of children. A new approach is laparoscopic evacuation if obstruction persists more than 7 days. So guys, I hope this explanation is clear. Now our next MCQ. Which of the following is correct regarding traumatic splenic injury? Okay, let's see all four options in traumatic splenic injury. Correct answers they want to ask: an elevation of WBC 20,000 mm cube and platelets to 3 lakh on post-operative day 7 is a common benign finding of post-splenectomy patients. Delayed rebleeding or rupture will typically occurs within 48 hours of injury. Common complications after splenectomy include subdiaphragmatic abscess, pancreatic tail injury, and gastric perforation. Post-splenectomy vaccines against encapsulated bacteria is optimally administered post-operatively or immediately post-operative. So which is single best answer? If you want, you can think, you can pause this slide and try to answer in a comment section and check how many answers you do correct. So best answer here is common complications after splenectomy include subdiaphragmatic abscess, pancreatic tail injury, and gastric perforation. Like see, unlike hepatic injuries which usually bleed within 48 hours, delayed hemorrhage or rupture of the spleen can occur up to weeks after injury. Indication for early intervention include initiation of blood transfusion within the first 12 hours and hemodynamic instability. After splenectomy or splenography, post-operative hemorrhage may be due to loosening of a tie around the splenic vessels, an improperly ligated unrecognized short gastric artery, or recurrent bleeding from the spleen if spleen repair was used. An immediate post-splenectomy increase in platelets and WBC is normal. However, the beyond post-operative day 5 WBC counts above 15,000, platelets ratio less than 20 are strongly associated with sepsis and should prompt thorough search for underlying infection. A common infectious complications after splenectomy is subphrenic abscess, which should be managed with percutaneous drainage. Additionally, source of morbidity include concurrent by unrecognized iatrogenic injury to the pancreatic tail during rapid splenectomy, resulting in pancreatic ascites or fistula, and a gastric perforation during short gastric ligation. Enthusiasm for splenic salvage was driven by the rare but often fatal complication of overwhelming post-splenectomy sepsis. Overwhelming post-splenectomy sepsis is caused by encapsulated bacteria, Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis, which are resistant to antimicrobial treatment. In patient undergoing splenectomy, prophylaxis against these bacteria is provided via vaccines administered optimally at 14th day, not immediately post-operative. So guys, I hope you like this video and every concept is clear. So if you want such more videos, do subscribe this channel. Don't forget to put like on this video. Thank you.